I think you guys, if you want to be safe and just maybe put it in the chat box, the questions.
Okay, yeah, no problem. We can do that.
Okay. And where is the chat box?
If you click more
at the top of your screen.
I'll send something. I just sent a message. Are you able to see it?
Oh, I see chat. Okay, got it.
All right, cool. We'll send in the comments through there and the questions too.
Okay.
Hello, web shadowers. Welcome to the first session of Summer Week 4. Today we have the pleasure of hosting Dr. Ramadan again. She is a pediatrician and she will be teaching us all about newborn hospital medicine. We're very excited and want to thank you all for attending the session today.
As always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. With all of that being said, Dr. Ramadan, you may start whenever you're ready.
All right, thank you guys so much for having me on here again. This is my second time presenting to you all, and I had a blast during our first session, and I really enjoyed it. So I hope that this session is also informative and we all have fun together during this session as well. I tried to make this one a little bit more brief and shorter so that we can hopefully have more time to answer questions and just chit chat about many different things or anything that you guys want to talk about. So hopefully we can do that towards the end. So a little bit of an introduction. You guys may already have seen this slide before, but I did undergo my undergraduate studies at the University of Texas. I got my Bachelor of Science in Biology there, and then I went on to do my medical school at Texas Tech University Health Sciences Center. And then from there, during my third and fourth year of medical school, I was really drawn towards pediatrics. And I was able to go through my 3 years of residency training through Baylor College of Medicine. So I've been in Texas for a very long time. Currently, I am a board certified general pediatrician, and I work as a newborn hospitalist. I have actually now completed 1 full year of being alone, being an attending physician, and so that has been really fun. So whenever I talk about, or whenever I introduce myself as a newborn hospitalist, I'm surprised to know that many don't know what a newborn hospitalist is, or that there is actually such a thing or a position as a newborn hospitalist. And I get frequent questions about, is there more training that's necessary to become a newborn hospitalist? How's the work-life balance? And so many other questions like that. So basically, what a newborn hospitalist is a general pediatrician. So there's no fellowship required. There's no extra training required. Pretty much whenever you finish your 3 years of general pediatrics training, you are well equipped and you have the knowledge and skills to become a newborn hospitalist. There are actually many general pediatricians in the clinic that will go to the hospital to perform the exams and see babies in the nursery, as well as have their clinic as well. I am only in the hospital, so we get to see many babies there. So that is what I do. I love being in the inpatient realm, although I actually didn't start that way in the beginning. I thought I preferred clinic, but during my residency training, I found out that I really did like being in the inpatient setting. So basically, newborn hospitalists, what we do, we're the first physicians to actually lay hands on the baby. So some of us, or most of us, will attend deliveries and provide resuscitation. We'll then take the baby to the newborn nursery, perform our initial exam, review mother's OB history, and we'll see why that's really relative in the upcoming cases. If there are certain things that require subspecialists, then we will work closely with those specialties and consult them if needed. There are procedures that we do. We will perform male circumcisions, we'll do lumbar punctures if needed. And the things that we're most well known for is, of course, providing lots of anticipatory guidance and really, reassurance and education, especially for first-time parents and even second-time or third-time parents, because things change and we, find that some things that we used to do in the past is now not the standard of care and may not be safe. And so we really want to update our parents about those things. So you guys really liked this last time. We are going to go along. I'm going to take you along with me. We're going to pretend that we are in the hospital. We just got there and we're going to start our rounds. And pretty much my day goes like this. I'll wake up pretty early. I'll wake up around 6 o'clock. And I will pre-round. So I'll open up my computer, go through the patients that I know I will have to see for the day, and kind of just make notes, quick notes as to maybe high risk things that I need to pay attention to, in mom's chart or mom's history, and review baby's labs, vital signs, and just kind of have a brief picture about which baby needs close attention and which babies are ready for discharge, and quickly just take a look at the OB board and know kind of roughly how many babies there are for me to see during that day. So I get to the hospital, the charge nurse will have a sheet for me with the census or the patient list. And again, I'm pretty familiar with the patients on there because I've done my pre-round during, in the morning at home. So I'm going to take you along with me. We're going to pretend that we've got in our patient sheet, our patient list, and we are about to go from room to room. So the first room we go to, room 204, guys, this picture is going to be brought up multiple times. We're going to pretend we're going to different rooms. But this patient is baby boy A, and we know that this baby was born at 40 weeks gestation. So baby is full term. He's AGA, appropriate for gestational age, meaning baby's birth weight and size is appropriate. He's a baby boy. He was born to G1, P1 mother. So this is a first-time mom via uncomplicated vaginal delivery. And we are called by the nursery nurse to assess this infant's foot. Before we go into the room, the nurse kind of calls us to the side and says, hey, this infant's foot just looks really weird. Just as a heads up before you go in and mom asks you a bunch of questions. So do you guys see the picture? And if you do, does anything strike you as abnormal? And feel free to use the question box. You can answer questions there. You can ask questions and answer them. So obviously there is a deformity, right? The patient's foot does not look like the other one, which is also a clue. All right, so baby has what we call clubfoot. And before I talk to you about clubfoot, have you ever heard of clubfoot? Have you seen babies with clubfoot? And do you think that this is painful? Do you think it's painful for the infant? Yeah, you guys are awesome. It is clubbed foot. Yes, or club feet or club foot. And do y'all think that this needs treatment? So let's go back. All right, so clubfoot is actually very common. It's one of the most common congenital anomalies, and it affects 1 in every 1,000 births. So I have seen a couple of them during the past year. If you can see from the other picture, if you want to describe this foot, how would you describe it? So the forefoot, right, this part here is turned inwards and it's plantar flexed, meaning the foot looks down. So it's a downward movement of the foot away from the leg. So If it was towards the leg, that would be dorsiflexion. When it's moving towards or down, it's called plantar flexion. It's kind of the same thing as if you're pressing on the accelerator or the pedal, the gas pedal while you're driving, so your foot is pressed down. So that's plantar flexion. So again, the forefoot is turned inwards and it's plantar flexed. And like I said, it's very common. And half of the cases, you'll see that it is bilateral, meaning both feet are affected. And we don't quite know why this happens. We think that this is an isolated or idiopathic event. And we have also seen some associations with certain syndromes. So right now we think that there's probably environmental and some genetic components to it. And at the same time, we know that it could be associated with some genetic syndromes like Down syndrome or amniotic band syndrome. Sometimes it can be associated with spina bifida or cerebral palsy as well. So one question is this because of the positioning in the womb? Excellent question. So, and do they use braces? Yes, we're going to talk about these. We're going to answer these questions, but excellent questions. So on prenatal ultrasounds, we will be able to pick up many of these club feet, but just because you see clubfoot on prenatal ultrasound does not mean that the baby will have clubfoot once they arrive or once they are delivered. And the reason why is because we need our physical exam to let us know. So the first question y'all asked was, is this because of positioning in the womb? So there is another event where due to intrauterine crowding or just the positioning in the womb, the baby's leg may look like that. So how do you differentiate? How do you know if this is just positional deformity that's going to get better on its own versus clubfoot? And the answer is your physical exam. So on your exam, if you want to distinguish between the two, you are actually going to try to stretch that foot out. So you want to bring it into dorsiflexion, remember, towards the leg, towards your tibia bone, and then you want to move it outwards. If you're able to do that easily and gently, and the foot will correct, then it's probably just the positioning in the womb. And you talk to parents about doing those positional exercises, and with time, it improves, it corrects, there's no issues. Now, a true club foot is going to be really rigid. You're not able to dorsiflex or bring it up past neutral. You're not going to be able to do that without hurting the child. And so that is a reason, or that's a way of knowing that this is congenital club foot. So what do we do? To answer the next question, yes, we need to correct and we need to treat this because it could lead to a deformity that will not correct on its own and can cause issues when the child is older. So pretty much in the nursery, we're going to consult pediatric orthopedics, and we're going to plug the baby in with the ortho team outpatient. And what they do is, so before, way back in the 70s or 90s, they would treat all babies with surgical release of that tight tissue, but they saw that it created a lot of scar tissue. It created painful feet later on. And so we now use something else. It's called the Ponseti method. And pretty much what that is, if you see from the photo, it is just serial casting. And that is the mainstay of treatment. So as soon as the baby is born, we want to start serial casting. We usually start at around 2 weeks of life. And the reason is we want to give parents a chance to, go home, get the baby on a nice schedule and make sure the feedings are established, and then plug them in and start the serial casting. So the serial casting is actually really intense. So they will do that in the clinic. and you leave the cast on for about 7 to 10 days. And then you go back to the ortho clinic and they will remove that, put another cast on. And so you will change the cast out in the office every week for about 4 to 6 weeks. So that is a long time. It could be shorter, it could be longer, depending on the severity of the deformity. After those 4 or 6 weeks are over, after we've done the serial casting, most babies will need another procedure that's usually done in the clinic. It could be done in the OR, and it corrects that final portion of the deformity that cannot be corrected with just casting. And that's the deformity where part of the foot is plantar flexed to the ground. So again, in the OR or the operating room, it's a quick procedure that kind of helps with that tight muscle to release it. And that second part of the treatment is done. Afterwards, we do the brace. So you guys asked, do we use braces? Yes. So this is also pretty intensive because when we remove that final cast in the clinic or in the OR room, we're then going to place the child in foot abduction brace, which is what you see from the photo there. And it helps prevent that clubfoot from reoccurring. And the reason why I say that this is intense is because for about the first 3 months, the baby will need to wear it for 24 hours a day. Afterwards, they can wear it for about 18 hours a day for the next 3 months, 14 to 16 hours a day for the next 3 months, and then 12 hours a day or during naps and nighttime, all the way until the child is about 3 or 4 years old. And you know, whenever you talk to parents about this, many of their questions are, will this prevent my child from walking? Will it delay baby's development? And the brace itself will not delay or compromise baby's development. And so baby will still be able to sit and crawl and walk during those times where baby is not, in the brace at all times. Now, what is the outcome? So after we've done all of that, the child is 3 or 4 years old. We've performed the treatments. We've completed it. Again, many parents will ask, well, what is the outcome? Will my child be able to, be a regular child? And the answer is yes. So the kid will still be able to, walk well, play sports, and do all of those things. And there are actually some famous sports players, don't ask me for specific names, who actually did have a diagnosis of club feet and were able to become professional players later on. One thing that you may notice is on the affected side, that calf muscle may be smaller, and then you would hopefully also plug in the patient with physical therapy to help kind of bulk up that muscle. All right, so now that we've reviewed all of those things, we go in and we talk to parents, we answer their questions, we come out of the room, and we are about to go to another patient room. So here we have baby boy B. We're ready to discharge this African-American baby boy who is born, and he is full term without complications. And on exam, we see this. Now, before you start asking questions, these photos are actually my own photo. So this is a baby that I saw, and as soon as I examined this baby, it was just a couple of hours old, I saw this. What do you guys think this is? And I have more photos for you guys as well. Again, this is the same patient. Oops. Oh, but the answer is up there. All right, so this is Amniotic band syndrome. This is really cool. It's not cool so much for the patient, but kind of the way it happens is impressive. So amniotic band syndrome is a rare condition caused by strands of the amniotic sac that actually separate, come off, and can entangle baby's digits, so fingers, toes, limbs, or even other parts of the fetus. And as the fetus is developing, those constriction sites or areas that are constricted may not be able to develop well, or the blood supply to those areas could be cut off, causing, as you would imagine, really bad consequences. So depending on where the strands are located and how tightly they're wrapped, you get a variety of different presentations. So again, just to briefly review, you have your fetus or the baby, and he or she is floating in amniotic fluid in the mother's uterus. What keeps the fluid around the uterus and in there is a sac, and that sac has two layers. So from the photo, you see the amnion or the inner membrane or the inner layer, and you have your chorion or that outer layer. And the one that is closest to the fetus is the amnion. And we think that amniotic band syndrome happens when that inner membrane, the amnion, either ruptures or tears, or for some reason, we don't know exactly, it will just kind of tear apart and have little strands that will be floating in the amniotic fluid and cause entanglement around the baby. So the incidence of that happening is about 1 in 1,200 to 1 in 15,000 live births. Again, we don't know why pieces and strands of the amnion come apart. But like I said, the clinical presentation can vary from really mild to pretty severe effects where it could even cause amputation. So let me go back up and show you guys the baby that I took care of. So if you see on the photo on the right-hand side, you can tell that something had wrapped around the baby's lower leg. And in other instances where that band wraps around, they could restrict baby's movement, right? And it could lead to deformities like clubfoot, like we talked about earlier. And if it's really severe, you can cause, again, possible amputation of the limb. If it's very, very severe, what could happen is if those bands become entangled around like baby's head or even the umbilical cord, you can cut off your blood supply and that can cause death. So it could be very severe. Now, this again is the same baby. So you have here, if you see where the two digits are fused, that's called syndactyly. So that's when the fingers or the toes become fused together. They kind of look webbed, right? And those could be treated with surgery. So surgical intervention could happen after birth where they will try to separate those fingers, but they will need to be plugged in with plastic surgery so that they can hopefully create a better outcome for the child. All right, we're on to the next baby. And I hope we're on time. All right, so baby boy C. This time we are called by the attending OB. She stops us in the hall and says, hey, there is a genital lesion that I found that's suspicious for herpes, and I'm going to be taking this mom to the OR room for C-section delivery right now. Just wanted to give you a heads up, she says. So what do you do? Are you concerned? Not concerned? What do you do? We panic, all right? That's not the answer. We don't panic. So what we do is while we wait for the C-section to happen, we're going to review the clinical guidelines for managing infants born to mothers with herpes. So let's do that now. All right, so herpes simplex. So this is a virus, and it is so there are two different genotypes. There's HSV or herpes simplex virus 1 and HSV 2. They're both envelope double-stranded linear DNA viruses from the herpes viridae family, and they will inoculate the mucosal surfaces of the skin. And what makes this virus interesting is that it does make its way up to the sensory dorsal root ganglion. It could live there and it can stay dormant. And during times of stress, it can be reactivated. So it comes back and causes the same symptom in the same mucosal surface. So now, why do we worry about this in the neonate? Well, it's because, unfortunately, HSV is very, very common. And, all right, I'm going ahead. And so because it's very common, having infants that are exposed to HSV at the time of the delivery is, again, not uncommon. And so we'll see that in many babies, and we need to make sure that we are able to prevent the devastating outcomes of neonatal HSV, which we'll see in just a few minutes. So usually the one that we are more familiar with is HSV causing cold sores, right? I mean, many of us have cold sores. And in pediatrics, we see, unfortunately, many kids with cold sores. And it can also cause something called herpetic whitlow, which is the one you see on the finger. This happens most of the time in children who suck their thumb. And if they have herpes or a cold sore or something in their mouth and they're sucking their thumb, then their thumb becomes infected as well. You can also see this in dentists. If they are not wearing gloves and they're working in a patient's mouth, they could be exposed and have herpetic whitlow. But we're dealing with newborns. So now, what do we do? So we are going to first figure out mom's history. It's super important that we go through the OB chart and notes and figure out what is going on. I'm going to make it simple. So there is a visible lesion on mom that is highly suspicious for herpes. We are going to look through mom's documentations. There are 3 things that we can find. So 1, mom may have no HSV 1 or 2 antibodies. So they tested mom, she didn't have antibodies. And yet she has this virus, she has a herpetic lesion. This would mean this is a first episode primary infection. So again, mom's PCR, or when we culture that lesion, that skin lesion that she has, is positive for herpes, and she has no antibodies, meaning she didn't even have time to create antibodies to this. This is an acute infection. This happened recently, and this is the most worrisome for babies. We'll talk about that in a few minutes. This presents the highest risk for infants. So about 25 to 60% of babies will have HSV infection if their mother is in that first scenario. All right, what about if mom has, again, a lesion that we swab and it's positive, but this time, let's say it's positive for HSV2, and we look through her blood, we test her blood, and she's positive, she has positive antibodies towards the opposite. So it's HSV1. We call this a first episode non-primary infection. So this is the second highest risk for babies if mom is in this scenario. What about if mom, again, has this herpetic lesion on exam, and this time the mom does have an antibody, so IgG antibody, towards that same HSV. So if she has HSV2, she has an antibody or IgG against HSV2. This probably means that she has a history of herpes, and it may have been dormant, kind of asleep, not really doing anything, and all of a sudden it reactivated. And that is what we call a recurrent infection. So thankfully, the risk for transmission in this case is maybe less than 2%. So again, the risk is still there, and we're gonna have to do things and work up for the baby. But again, it's not as high risk as the other two scenarios. What makes this troublesome and worrisome, and why we panicked in the beginning, is because sometimes moms with genital HSV could be asymptomatic. So she may not have a lesion, she may not have any symptoms, and she can still transmit this to the neonate. All right, so again, you open up your red book, you open up your infectious disease guide, and we are going to review mom scenario. So the first thing we're going to do after we review everything is, of course, we're going to examine baby. Now, if baby is symptomatic, baby has any symptoms, we're gonna stop. We're sending baby to the NICU for IV medication, IV acyclovir, antiviral medication. But if baby is delivered and we're examining baby, baby looks pretty good, no symptoms, then we are going to look through this algorithm. So this one here says asymptomatic neonate, which is the one we have. This is following vaginal or cesarean delivery to mother with visible genital lesions that are characteristic of HSV. So that's where we're at, right? Now our OB friends are going to obtain a swab for mom's lesion. They're gonna send it off for HSV, PCR, and culture to tell us, is this lesion really herpes or not? Now, yes, it came back positive. So we are sure that this is a herpetic lesion. Now we ask ourselves, well, does mom have a history of genital herpes prior to this pregnancy? If she does, then this is a reactivation that we talked about, and it's less risky, right? It's still a risk, but it's less so than the other one, where this is her first occurrence. She had no history of herpes before. This is her first time. So if that's the case, we're gonna check her antibodies. Again, when you go back, if her antibodies, if she does not have any antibodies, that means this is a recent infection. It carries the highest risk for baby. So what do? At 24 hours old, we're going to obtain specimens from the baby. So why are we waiting to 24 hours old? I thought this was a serious infection, right? The reason why we're going to wait till about 24 hours of age is because we want to make sure that we kind of gave it some time to differentiate between, is this just a contamination from mom's tract, or is this true viral replication? We gave it enough time. If it's truly infected, if the baby's truly infected, the virus is going, right? It's replicating. And so what are we going to obtain from the neonate? We're going to take HSV surface cultures. What are surface cultures? So that is going to be, we're going to take a culture from baby's eyes, conjunctiva, the mouth, the nasopharynx, if we had the baby's rectum, and if we had any scalp electrodes, meaning certain things that the OB will put on the baby's scalp while baby's still inside mom to make sure that baby's heart rate and everything is all right. If that was put on baby, there's a chance that it could cause abrasions, right? And skin breakdown. And so we would test those sites as well. Because again, this is mom's first infection. She doesn't have antibodies. This is a very, very high risk situation. We're going to do an LP or a lumbar puncture and get CSF studies. And we're going to check baby's blood to make sure that is there HSV in the blood as well. And we're going to go ahead and start IV acyclovir medication. Now, again, this would be a patient that we would need to send for the NICU. They will be on IV medications for a long time. And so this is not a baby that we would keep in the nursery. But on the other hand, if, again, we see mom has a lesion, it's positive for HSV, and she does have a history of genital herpes before pregnancy, this is a recurrent infection, again, it's still at risk. So we're going to get at 24 hours old HSV surface cultures. Again, we're going to swab the mouth, nose, the rectum, scalp electrode sites. We're going to get HSV blood PCR. Again, baby is asymptomatic, have less than 2% chance of infection. We're going to not start the medication. We're going to wait and see the results. So if all of those cultures and PCR come back negative, great, baby can go home. However, if we see that any of those surface cultures are positive or the blood culture is positive, we're in trouble, right? This would mean that, again, we have to now complete our workup by getting the CSF studies to make sure that there is no herpes in the cerebrospinal fluid. And we're going to go ahead and start treatment with IV acyclovir. All right. Now, again, unfortunately, neonatal herpes simplex viral infections do happen. When they do, how does a baby present? Well, there could be 3 different clinical presentations. So one could be called SEM, or skin, eye, and mouth disease, where pretty much the herpes virus has infected the skin, the eyes, and the mouth, and you see vesicles on those 3 sites. You could have localized central nervous system disease, where it's only in the CSF, or cerebrospinal fluid. Or you can have disseminated disease, where it is through the bloodstream, it has involved multiple organs, and it's very, very concerning. So again, the characteristic finding of herpes, and you're gonna hear this phrase all the time, is you'll see that it's clustered vesicles on an erythematous base. You're gonna hear this phrase used many, many times to describe herpes, and that's what that picture down here is showing. All right. I also want to take a moment and remind everyone that newborns can be affected during birth, but they can also be affected after birth. And it's really sad because you could have the mom or even a family member with a cold sore or prodromal symptoms, meaning they don't see the cold sore yet, or anything like that, where they can pass it on to the baby. They don't know that they're shedding the HSV virus in their saliva, and unfortunately can pass it to baby. All right. Do you test for these things during the prenatal care? So they'll test for it if there are lesions or if mom has a history. So for example, if mom has a primary outbreak or has a herpes outbreak in the beginning of the pregnancy, Then they will treat mom with medication, and she will continue taking what we call suppressive medication to help prevent a reactivation of that disease, so that it does not happen again, and it doesn't happen at the time of delivery. All right, gosh, so many crazy babies. Who knew? All right, so next baby. Here we have a 38-week gestation, AGA, so appropriate for gestational age, baby girl born to G3, P3, so this is mom's third child, via spontaneous vaginal delivery, and she presents with a neck mass. All right, again, this is a patient I recently took care of. Now, what the heck is going on? What is that? So honestly, this was kind of tucked in. I did not see it until I lifted up baby's chin and took a look, which is why physical exam is really important, because you are the first physician to lay hands on that baby. You need to make sure that you are doing a pretty thorough exam. So I called this a 0.5 centimeter cystic mass just above the sternal notch. It was not painful, it's non-tender, non-mobile, kind of flesh colored, maybe a little white lesion on the neck. Now, should I just let it go? Kind of odd, weird, right? Just tell parents, don't worry about it. Or should we dig closer? Now, anytime in pediatrics you hear about anterior neck masses or midline neck masses, you should pause and kind of reflect about what may be going on. So it's not something that you can kind of just disregard. So these are not newborns. I couldn't find images, but again, anytime we see a neck mass, we want to at least classify the mass and kind of figure out what it is. Now, 3 main ones I want to talk to you all about is 1, thyroglossal duct cyst. And basically, this is the first picture that you see here with the red arrow. Basically what that is during development, as the thyroid gland is descending to the right location, it may cause, a cyst or along the tract of where it's descending. This cyst could be a cause for recurrent infections, and most of the time it's missed in newborns. You don't see it until later on when it becomes infected and it's large and icky, and then we realize, hey, this boy has a thyroglossal duct cyst. One thing that can help you differentiate or kind of distinguish this from the rest is if the baby's old enough or the child's old enough, you can ask them to stick out their tongue, and with tongue protrusion, it'll move because of, again, the location of the cyst. Another one, this last photo, cartoon photo here, is a branchial cleft cyst. And again, during development, the neck is a really complicated area of the body, okay? And there's lots of developmental things that happen in utero. And anytime there's any sort of disruption, a cyst or a potential space can occur. And a branchial cleft cyst is usually alongside the sternocleidomastoid muscle. And so most of the time it's on the lateral side of the neck. Again, sometimes most often we find out that it's there when it becomes infected later on. And then this one in the middle here is a dermoid cyst, which again is another congenital defect that's present since birth. And again, it happens during embryonic development where the skin layers don't really properly grow together. And so you have this cyst that's filled with epithelium, it's filled with skin oil, sweat glands. And as you can probably imagine, once those glands and tissues secrete their normal substances, it can grow bigger, and those things can collect inside the cyst, causing it to grow and enlarge. But ours doesn't look like any of those, right? Those were the three common ones. So I did a literature search and I saw that there was another condition called manic. And it stands for midline anterior neck inclusion cyst, where it is a superficial papule and it has no apparent deeper connection, and pretty much it does not cause any harm to the baby. I did get an ultrasound to make sure that baby's thyroid was, there was normal thyroid tissue in the normal location, and there was no deep connection towards any of the underlying structures. As soon as we got those cleared, then I spoke to ENT, because the treatment for all of those things are surgical resection. All right, how are we doing on time? It's 4:25. I am going to stop here because I do want to give you guys a chance to ask questions. They don't have to be regarding these patient cases. You can ask me any questions about peds in general, or about my job as a newborn hospitalist. I think there was one more patient case, but I'd rather answer your questions. So if you have questions, let me know. And I'm not able to see the questions right away, so I have help, but that's why the questions are delayed. All right. Are you the first that examines the newborn? Do you determine their APGAR score, or whether they're able to go to hospital nursery versus need more care like NICU? That's an awesome question. So if we attend the delivery, then we are the ones to assign APGAR scores, and we perform that initial resuscitation. So we want to make sure that baby is stable. So some babies will need some help during their transition time. Some will need CPAP or respiratory support. Just for a few minutes, we're able to remove it, and they perk up and they do well. And those babies we're able to take to the newborn nursery with us. If they don't, or need more high flow ventilation or intubation, or more invasive support, then of course we'll send those babies to the NICU. Now, if we know, if this is a preterm baby, we know for sure that we're not going to be the ones to take care of this baby. So the NICU will be the ones, of course, to attend those high-risk deliveries. Do you work with PAs? I actually do not. We don't have PAs where I work, but if you are a newborn hospitalist, you may work with a lot of NNPs, so nurse practitioners, and they actually are available overnight. And so we will sign out to them or let them know about babies that we may be worried about overnight, so that they can assume their care while we get some rest. About how many patients do you see per day? Yeah, so, it varies. Of course, we're trying to see as many babies as we can. Usually, though, I will say the most I've seen was in the 30s, 30 plus patients. That can be overwhelming, especially when you have, a couple of patients like the ones we had today. Other times I may see maybe 15 or less. So kind of just depends, honestly. How did you know pediatrics was for you? So honestly, I was actually between OB and pediatrics. I just loved being in the labor and delivery rooms. I loved being with the mothers and helping them, encouraging them, and just working with them. But I saw that once that baby was out, I tended to go with the baby and kind of forget about mom in those few minutes. So that's how I knew that I really loved working with kids. Again, like I said, I didn't know I was going to become a newborn hospitalist. I honestly thought I was just going to do general pediatrics and work in the clinic, in the outpatient setting. But when I rotated through newborn medicine during residency, I just fell in love. Again, it brought back all of that OB experience that I really, really liked during med school. And so I just loved that environment where you're taking care of those who have no voice, right? They can't tell us what's wrong. They are dependent on you fully to be, ethical, to make sure you're doing a really thorough job. It's very easy, super easy to miss many, many newborn findings. You have to know what you're looking for, and you have to know normal versus abnormal and do a thorough and just a good job of looking the baby over. Where are we? Let's see. What do you do when mothers refuse treatment for themselves or their babies? Again, it happens. There are certain things so for a newborn, we will pretty much have to give babies the erythromycin ointment for their eyes to prevent gonorrheal infection. We give vitamin K shot to prevent hemorrhagic disease of the newborn, and we give their first Hep B vaccine. We do come across parents where they refuse one or all of those things. And it's a matter of establishing a good relationship with the parents, asking them what their fears are, why they're hesitant, and just honestly just being very approachable, non-judgmental, sit down, talk to them, tell them the evidence, show them the evidence, and just show them that you have the baby's, that baby in that baby's best interest. And so just by communication, you can do a lot. Is there a special fellowship in peds to work with preemies? Yes, that's what neonatology is. So neonatology is a fellowship. You have to go through fellowship for that in order to work with the preemies, the babies on ventilation. How do you build a connection with parents who trust you with newborn infants? Again, we talked about that, just being non-judgmental, giving them the facts, being approachable. Do all newborn doctors have to work on call? So the good news is no. So I work 7 days on and 7 days off. So I will work from 7 A to 7 P from Monday through Sunday. And then I'll have that second week off. So from Monday to Sunday, I'll be off to recover and have a few days to enjoy, life. And then I'll work the next week. After 7 p.m., I usually do not get calls. All calls will go to the NICU or NNP who's covering the unit at night. What advice would you give to minority, underrepresented pre-med students? Yeah, so I am a minority, and I'm actually a mom. So I'm a mom to 2 kids. I had my first baby boy a couple of months before I started med school, and then I had my daughter during residency. So as a mom in medicine, as a minority in medicine, I can answer that question really well. Honestly, the first thing that I would tell you is that you need to build the confidence from within. You have to know that you belong, right? Medicine is for everyone. And we need doctors from minority groups to advocate for those minority groups and to know what kind of things those minority groups need. It is really important to know that you belong. Medicine needs you. You can do it. Many of us have, and you are not an exception. Do you follow up with the newborns? If so, for how long? So, as a newborn hospitalist, you are only taking care of the baby from once they're delivered, so once they're born, until discharge. Usually in the newborn nursery, it's 1 or 2, maybe 3 days that the baby stays with us if this is a healthy newborn, right? On day of life 2 or 3, baby is discharged. We are not required for follow-up. That's when the pediatrician in the clinic will assume the baby's care until, they'll see them for their well child checks until baby's much older and is no longer a baby. So we don't follow up after we send the babies home from the hospital. This might be a more personal question. What was it like to have children during med school? So I had one, and it was difficult. So to be completely honest, it was not easy. Was it doable? Yes, because I did it, and a lot of women have done it. You just need to be very organized. You need to have a good support group. So if you have a partner, that partner needs to be supportive. But you can also do it as a single parent. So during residency, my husband actually had to move for his training. And so we were apart for almost 2 years. So essentially, I was functioning as a single parent with 2 kids during residency. So it was still doable, and it was hard. It was really hard. But again, it's about finding a support group, people to send the kids off, to their homes. If I'm doing night float, if I'm on 24-hour call, who's going to pick them up? Who's going to provide for them and care for them? And it's just a lot of extra things that you will have to worry about. But I would not trade, my kids for anything in this world. And I'm glad that I had them when I did. All right, one more question, and then we'll have to go. Let's see. What other fields were you considering besides pediatrics? I've already answered that. I said it was OB, GYN. I really wanted to deliver babies. All right, guys. I think that'll be all for now. I'm going to go down to this quote that I wanted to share with you guys. I shared it last time, but I wanted to wrap up with just saying that I know it's difficult, really, really difficult, this path that you're on. But if you know that what lies overhead is what you want, keep moving towards it, and you will eventually reach it. All right. This is my Instagram handle, and this is my email. I will check both frequently. So if you have other questions that I did not answer, I apologize. But those are 2 ways that you can reach me.
Thank you so much, Dr. Ramadan, for presenting to our web shadowers. We love how entertaining and informative you make your presentations, and it's always an honor to have you back.
It was very fun this time around as well. Thank you so much.
Thank you. Everyone, make sure you check out her socials. Her Instagram is alaa.rama.md.
The link to today's Google form is now going to be posted in the chat and will also be in the description of this video as soon as it ends. Please fill it out within the next 30 minutes. And again, thank you so much. This was such a cool presentation, and I'm sure everyone was loving all of the photos and you taking us through the hallways and into the rooms.
It was my pleasure. Thank you, guys.
Everyone's saying thank you, and they're calling you Super Mom.
Yeah.
The sweetest.
And they found you inspirational as well. Thank you so much.
Did you end it?